we're enormously grateful to Karinya, um, and we invite speakers who are knowledgeable on the topic. The information shared tonight is based on their own experience, and knowledge does not replace individual medical advice. Your circumstances are unique to you. So if you are thinking of making any lifestyle or medical changes as a result of this webinar, please speak to your eye specialist first. Glaucoma UK and Karinya are not responsible for any action you may take as a result for this information you learn from this webinar. So now we are going to start with the questions. So the first question is this lady was diagnosed 3 years ago and they put drops in every night. So what treatment what do their future hold, please, about their glaucoma journey?
Oh, well, thanks, Conchita. So it's lovely to be with everyone this evening. I think, as Conchita said, my name's Karinya Lewis. I'm a consultant. I work in Salisbury Hospital, yeah, quite passionate about glaucoma and obviously trying to keep everyone's vision as good as it can be. So I would say in my practice, and again, this is very different for individuals. There are about a third of people for whom we diagnose with glaucoma, and they're just on one or two drops, and that's all they need to do, and that keeps their vision for as long as they need it. I've got a sort of group in the middle, another third, for whom we have to try a few different options that might involve drops or laser, and then about 20%, sometimes up to a third of people who are whose glaucoma just seems to accelerate or get a bit more aggressive and needs more intervention, and that might progress onto surgery. So it's quite a wide range of different scenarios that could play out. For most, I think that the challenge is that we are trying to detect a disease before it becomes a problem for you. So quite often it's hard to work out how things will change until we've got a sort of a year or two or even 3 years of data to work out whether your glaucoma is going to stabilize, whether it needs a lot of help or whether it needs just one drop at night. So it can be quite variable. So it's hard, I'm sorry, to answer that directly without seeing, I guess, at what stage you've come into the system, and again, what interventions are there. But I'd say that there's a bit of a broad spread, and for the most part, we're really trying to get the opticians to pick up things early, that if we intervene and act early, then the vision, most people are almost unaware that they have glaucoma apart from having to put drops in. Hope that helps to answer that question.
No, that's really good. It's about early intervention, isn't it? So the next one is about kind of, I suppose, night times. Why are drops, like if you have a single use drop, only one drop a day, are they always at night? So can you explain what the body's doing and why they work more effectively at these times?
Yeah, so this is a really great question, and there's a few different answers to the question. But what we do know is that your pressure, like other things in the day, will vary. So you've got what we call diurnal rhythms. So those are day and night rhythms. So in your body, so the bit where we feel tired at night is related to some pigment in our eyes and those cycles which make us feel sleepy. And when we sleep, the body goes into recovery and rest mode and to restoration. In the day, then we need to be active and awake. And actually, those body rhythms are really important, as anyone who's taken a long haul flight will know that jet lag just can make you feel pretty awful. So why am I telling you that? Well, the reason is that the eye pressures also vary, and they tend to go highest at night, usually between about 11 and 6 o'clock. And the difficulty is that you probably know that all our clinics are usually between 9 and 5. So we're not always catching your highest pressures when we're trying to make decisions about glaucoma. But on the basis that those drops that you use once a day usually have a sort of 24-hour, and by the end of 24 hours, they're beginning to wear off. So trying to make sure that your nighttime pressures are best covered is quite helpful. So that's the sort of physiological reason and the response to the question about what's our body doing. So we do know that pressures tend to be higher overnight. The second answer is that sometimes people feel that actually at night time they've got a good routine. So brushing your teeth and going to bed is often a fairly stable point in the day, whereas you might get up earlier one morning or later another morning. So for some people, the nighttime routine with brushing your teeth and going to bed is a good opportunity to get to put the drops in regularly. However, most of the drops that are once a day drops can be put in once every 24 hours. And particularly I notice with people who are shift workers, they say this is really struggling. Sometimes on a 7 p.m. shift, sometimes I start on a 10 p.m. shift. But I actually, for me, when I come in from my shift first thing in the morning, and on my days off, actually that's a better time for me. So whilst most of the time we would say put it in at night to cover the body variations and the higher pressure at night, the most important thing is that you're regular and you put it in at the same time. So for you, actually doing it once a day in the morning or whatever time, every sort of 24 hours is the best time for you because you're more reliable that way, then that's a preference, then that's the priority over it has to be at night time.
Now I never thought about that's a really good idea because obviously having a shift workers, you're kind of like topsy turvy, aren't you? So it's having that kind of good routine. So I've got one on side effects here. So since diagnosis, there have been felt increasing fatigue and unsteadiness, in particularly in crowded places and especially with bright lights. Is there any connection with the glaucoma diagnosis?
Um, so I think there's two bits to that question, and I'll just try and unpack them separately. So um, there was a comment about tiredness and unsteady on your feet, and there are some drops. We particularly think of the beta blockers that might make you have a slightly slower heart rate. And if that's the case, often when you go to stand, your blood pressure just takes a while to catch up with the rest of your body that's standing up. So we are cautious. And if anyone came to me and said, actually, I'm having difficulties feeling dizzy and unsteady on my feet, it might be that I do a trial without that particular drop to see if that's affecting you. It's a tiny, tiny dose. And it is a medication that's used in much bigger doses in tablets for things like blood pressure or people who've got fast pulses. So it is a medication that is used elsewhere, and the doses that we particularly use in eyes is quite a small dose. So it's not much of it gets into the main blood supply, but some people are more sensitive than others. Some things that can help is if when you put your drop in, you use your finger and you just find there's a little squishy spot right in the corner there. Those are the little tear ducts that take away your tears through the back of your nose. So you'll notice that if you ever have a good old cry, you get a really stuffy nose, and that's because the tears drain through to the nose, to the back of the mouth. And so if you can block those little tear ducts, then more of the drops that you're using in the eye just absorbed into the eye and less of them going through to the back of the throat and into the body and the system. So that's sort of our top tip for putting in drops and trying to avoid side effects. I think your second question was around glare and lighting conditions. And that usually is intrinsic to the glaucoma itself. So people talk about if you've got significant glaucoma, people find it really difficult because they say if I go into a bright like a supermarket with all the strip lights, I feel quite dazed and glared out. But if I go into a dark room, it feels like it takes me a lot longer to be able to see things. So the range of light that works for glaucoma is interestingly incandescent light. So it's that candle, that wavelength of candles is probably the perfect light for people with significant glaucoma. It's not too bright that they feel too glared out, and it's not too dim that they're struggling in that light. But that is more in significant cases. Occasionally, if the drops have more preservatives in, or if you're using lots of drops, the surface of the eye can get irritated, and then that can make you feel a bit photophobic and light sensitive as well. So again, it's worthwhile just mentioning these things at your appointments if you're feeling that you're struggling, and I guess having a conversation about whether there might be alternatives and whether in your particular scenario they are likely to be contributing.
Thank you. So we've got a little bit of treatments now. So this person has used a couple of different drops, and the eye pressures are generally in the high teens, and their consultant has recommended SLT, and they don't know much about it. So do the benefits of the treatment outweigh the possible risks, uh, as it would mean that they may not be able to, they may need not to have to use drops in the future. So about sort of
Yeah, so thinking about laser
the potential of
treatments.
not using drops.
Yeah, so laser treatment always sounds much scarier than it is. We're really lucky in the UK to have hosted the big trial at Moorfields, which was called the Light trial, and this was looking at laser SLT laser, so that's called selective laser trabeculoplasty, compared to eye drops, and the evidence showed that it actually had a great safety profile for patients, and that it was quite as effective as using one drop. So if you're on more than one medication, and remember, some of you might have drops which are two medications in one bottle, so we tend to think of medications as the active component. So you might have one drop, two medications. So we know that if you're on one medication, and that the laser is equivalent to that. The laser is basically, and this is, just bear with me, this is an analogy that sometimes works for people, sometimes isn't helpful, but I'll share it in case it helps you. But in your eye, you've got a meshwork, which is a bit like a sieve, and that sieve filters particles that are in the eye, and gets them to be recycled. So the eye is always producing fluid, and that fluid is being recycled as it sort of provides nutrients to the inside of the eye, but again has to get out of the eye. So that little meshwork is the filter. And that meshwork with time, a bit like your leaves or your gutters, gets blocked up, which is why glaucoma is a disease that comes, unfortunately, with extra birthdays. So when the meshwork is blocked up, it doesn't work so well, and the fluid in the eye can't get out of the eye, and your pressure rises. So the laser treatment applies a little bit of heat and energy to the little meshwork, and that encourages these strands to do a couple things. One, to remodel themselves, and the best way I can describe this is a bit like you've got a sieve and maybe you're trying to get more of a colander, so that will let more fluid out of the eye, but it also creates a little bit of inflammation in the eye, and that's designed to signal to the cleaner uppers who can come and clean up the little pores and try and improve the flow. So it, as I say, it works in two ways: one, to remodel, and two, to recruit the cleaner uppers. So that laser has been shown to be quite effective, and the difficulty the challenge I have is that for some people that treatment can last up to 5 years. For some people it only lasts about 6 months. So we do need to repeat. You're never cured of glaucoma if you have the laser treatment, but it is an alternative to drops, and it's trying to, I suppose, restore your natural system by helping it to work a bit better. When I talk to patients about SLT, there's a lot of people who sort of imagine horror movies and crazy lasers in the eye. But in the reality, it's really not much more than your normal eye test. And I know lots of people don't like putting their little chin onto the rest and sticking their head through the window and having their eyes fiddled with. But most of the time, that's as sort of uncomfortable as it is. So I tend to say it's not your favourite day out. It's a bit like having a blood test, so you don't look forward to it, but it really is quite a short procedure, and it's not particularly painful. You'll see lots of flashy lights and bright lights, and then by the end your eye might just feel a little bit achy, but some of that's to do with just us keeping it still and holding it in the right place. I advise my patients that they come in and they have some drops. So there's about sort of 40 minutes lead up in terms of the paperwork and in terms of the drops working. And then we do the laser. And then I sort of say, so don't drive to your appointment. And then after the laser, you can go home, but don't drive for the rest of the day. But most people, there's no time off work. You're back to work the next day. your vision shouldn't be significantly affected. It's just a bit blurry on the day that you have the laser, but the next day it's usually back to normal. Sometimes the eye might give you a couple of aches for a couple of days, but it's not particularly painful procedure. In terms of safety, as I say, the safety profile was quite nicely established by the light trial, which showed that actually patients' quality of life was better without drops and in preference to the laser, and that was a reasonably, less than 1 in 1,000 had an incident with it. So my main worry when I counsel patients about having laser treatments is this may not be enough or work enough for you, and it may wear off, but I'm not overly concerned about complications because they are very rare.
You. This is another one about SLT actually. It's about they've recently undergone it, but how long before the checkup appointment? They have a checkup appointment that's coming up soon, taking their drops when their eye pressure is going to be checked. So I don't know whether that
Yeah,
makes sense.
no, that's a really good question. So the laser doesn't work straight away because it needs these little cleaner uppers to come along and do that, and the eye needs to the meshwork needs to restructure. So we tend to give it about 4 to 6 weeks before we see the patient afterwards. And the difficulty is if we saw you more like 2 weeks, we might not know whether it's worked enough. So about 4 to 6 weeks is the time frame when we would expect to see how the eye's doing, what the pressure's doing. In terms of stopping drops and how does that all work, people do that differently. So I can't really speak into a standard of practice. And again, for some people, it might be that they're having laser treatment to in addition to their drops. And for some people, it might be that they're having laser treatment in order to get rid of a drop or the side effects from a drop. So it's not, so again, it very much depends on why the laser's being done. And then equally, what are you trying to achieve for it? So in our practice, we try and set a target laser, target pressure, so that when we see you back again, we kind of know whether we've achieved what we wanted to achieve. For some people, it might just be getting a pressure down from 30 to 20. For other people, it might be getting from 20 to 15. So it's very individualized care. And so how effective it's been is I can't tell you how that is, without your own pressure readings and without looking at the bigger scheme of things, which is the other tests that you do in glaucoma. So the visual field test and the optic nerve imaging tests as well. So yeah, so I think in summary, the answer is 4 to 6 weeks is when we would expect to see the result. And some people might say, stop your drops before your next appointment so we can see what the laser's doing. Other people might see you at 4 to 6 weeks and then do a sort of phased reduction of medication, depending on whether reduction of medication was the goal.
That makes sense, absolutely. So we're staying with treatments and we're going to talk a bit about the traps. So this person is a reason that post-trab surgery, so this surgery took 140 minutes under general anaesthetic, but the non-operated eye's vision is becoming progressively fainter. Was it connected? Is there a reason for it?
Okay, just clarifying the question. So it sounded like the glaucoma operation in one eye was long, but the other eye is also struggling now. Is that correct?
That's it. Yes, it's a non-operated eye's vision is becoming. It's unsure whether the other eye has what type of, what's the progression of glaucoma in that second eye. But the operated eye was a long operation, but the non-operated eye is now visioning fainter.
Yeah, that's kind of a tricky one without sort of seeing the two eyes. So if you have a general anaesthetic, the eye that we're not operating is usually taped shut, but it can dry out in that time. So sometimes people wake up and they're in a little bit of panic because the eye they didn't have an operation feels misty, and sometimes that's just dry eye. So it's difficult to know from this question if you're talking about, they've had an operation in the last week or this is 6 months down the line from that.
No, I understand that. And there's another one on so how long would you hope that a surgery such as trabeculectomy will keep glaucoma under control? And do you need to redo this kind of ops? Like maybe they said maybe like a hip hop.
Okay.
You might need a new hip. Do you need a new trab?
Yeah. Yeah, great. I'll just sort of just catch up on the last visit, just a comment on the last question as well, which was
Oh,
just
sorry, yes.
if you've, I guess, without knowing that time frame, it's just well, often I have to confess that once we've done surgery in one eye, for the sort of 3 months after that eye that we just operated on, we're very fixated on getting that one sorted and settled, and we're not paying so much attention to your other eye. So if you do feel that you are worried about the other eye, it's it's very perfectly acceptable to say, oh yeah, I know we've done one eye, but could we just check in on how the other one's doing? Because sometimes they are in tandem, and one goes first and then the other one catches up after that. But yes, I know that in my mind I tend to focus on one eye for the first 3 months, and then we get to the end of the 3 months and we go, right, what's happening with the other eye? And we run through all those visual field tests. But when you're in the post-operative period, we tend to just be following the pressures and not doing our whole workup. So I think if you've got concerns about that, it's good. It's a good reminder to us clinicians that you've got two eyes, and if the other one isn't feeling great, we need to follow up on that one. So your next question is about trabeculectomy. So yes, I suppose if I explain the basis of a trabeculectomy is a paradox. So we are making a cut and a hole in the eye, and if you had a cut or a hole anywhere else in your body would work really hard to try and close that hole. So it is we are trying to beat nature, so to speak, and that's why if you have a trabeculectomy, we see you on day one, and we see you really closely in the first, almost for some people every week in the first month, and then it gets a little bit longer until we feel that the eye is very stable. So some trabeculectomies will last a lifetime, and they just seem to nip things in the bud and do really well. But what we're very mindful of is that even after getting to the sort of 3 month point where trabeculectomies are settling down, they still, if we look at studies of the shape of the area of drainage, and we call that area the bleb. So if we're looking at the bleb area, we will see that like scar tissue anywhere else in the body, it does continue to change for quite a long time after the initial 3 months and form. And our worry is that scar tissue will close over our little trapdoor that we've made, and therefore the surface area for the fluid to escape to gets smaller and smaller. So for some people, they may need to have a further procedure which helps to remove some of the scar tissue and to put another treatment of anti-scarring in to try and increase the surface area that bleb can drain into. For some people, though, they are just great healers. So in some ways, every other surgeon or every other operation, you would be praying for a good healer. But in our case, we want people who don't heal rapidly or too fast. And there are some people who just heal over that trapdoor and that scar it down really, really quickly. And there are other options in order to achieve that. To get the pressures down, they often need a different procedure that is less prone to scarring over, but any procedure we do has a risk of scarring. So the main thing about trabeculectomies is that we do need to look after them really closely in the first 3 months, and particularly in the first month, in order to control that scarring. And we put anti-scarring treatment in at the time of doing the surgery. If you're going into an operation, your eyes are very sore or inflamed or red, or if you've got underlying inflammatory conditions, those tend to scar more. So again, that can be a bit of a challenge. And then again, after the surgery, even years later, if you then have something else that makes your eye irritated, it can sometimes then start to try and close that trapdoor, that scarring process again. So we're very aware of that. If we then go on to do a cataract operation, say, for example, we tend to give you extra anti-inflammatory drops after cataract surgery to avoid that trabeculectomy scarring over. But that could also apply to trauma, or if your eye gets irritated or you suffer with hay fever. So anything that makes the eye irritated can start that sort of healing process again. So it can be quite variable, and for some people it can be very challenging.
Thank you. So we're still sort of with treatments, but what would you advise for someone who's not really sure if, about surgery, if that's the next step? They're kind of really kind of like concerned about surgery. What would you advise?
Yeah, that's a really, really good question. I think nobody volunteers for surgery. Nobody wants to jump in and have surgery. And so getting to that point of surgery can be quite challenging, and trying to get your head around it. So there's a few steps that you can sort of go through in terms of that process. So obviously your consultation is really important to ask your questions. And I have to say, in my practice, we absolutely love the glaucoma. That's not just because I'm on this little podcast, but it is just a huge credit to the Glaucoma UK team, who've got some lovely, really, really clear, lovely pictures, information, and really comprehensive as well. So actually, although we developed our own little what's glaucoma and what's a trabeculectomy and things to think about, I order in all the Glaucoma K ones because I just feel the patients who read that have a really good overview of what's going to happen and how the process works. And I ask people to read it 5 times before surgery because there's a lot of information and it's not a lot. I can't convey all that information in my short time with people, and people can't retain it. So I think having some written information about surgery is really helpful. I think having a chance to think about it. So I suppose anyone who's listening to this meeting this evening, it's just mindful that we do have a range of options. We have drops, we have laser, and we have surgical options. And you may move from one to the other. So it's not to scare you, but it's just to say those are always on the table, and they're all always options for different reasons. At the point where you get into thinking about surgery, it is helpful to be able to ask your questions. And again, that can be either in your consultation, but the Glaucoma UK do a buddy system, so you can have a chat with a buddy about, oh, you've had surgery, what was it like? So although our leaflets are great and tell you what it's like from our side of things, it's really helpful to talk to someone who's had it before, and just the ups and downs of the practical things you have to think about in terms of organising life around having the surgery. I guess if you're in that situation where you're feeling really reluctant, in my case, I kind of go through why I think the other options aren't great. So whether we've tried all the drops that can go in. There are some people who aren't suitable for laser. There isn't enough space to do that, or they have a contraindication for a reason why we wouldn't do that. So usually another eye condition, that means we wouldn't laser. And I suppose laser surgery is really difficult because you don't want to take a risk with your eyes, and I really understand that. But we have to remember that glaucoma is the silent thief of sight. So a lot of the time I have to spend showing people their visual fields, showing people their optic nerves, showing that there are changes happening that they are not aware of. It's not affecting them. They're functioning very well. They see very well. They can't actually imagine that they even have a problem. But our imaging is very helpful. We're really lucky to be living in a digital era because the imaging is quite clear and demonstrating change that is going on in the visual field. And so what I say to patients is that as much as there is a risk of surgery, usually I can show you a graph that shows you if I don't do anything to intervene, you're on a trajectory where the vision will just continue to be lost and we can't get it back. So if you think of something like surgery as being a little bit of a pension, and in fact all glaucoma treatment, we are trying to put in things early so that when you need it, you have it later on. So surgery is a bit scary, and there are risks with it. Most things can be managed if you are able to get to your post-op appointments, and they can be corrected. So as much as you might have surgery, that we do sometimes have to take people back to theatre, and that's probably about 1 in 20 patients that we do need to go back to theatre. The vision may actually get worse, and it certainly is for the first month, but it often then stabilises And although you might not see as well down the chart, actually in terms of managing and slowing the glaucoma down, that can be really successful, and it's a compromise there. I think if you've had those really honest chats and you're still not convinced that this is the right treatment for you, you are entitled to ask for a second opinion, just to help you to feel confident that this is the right decision for you. However, what we really value in glaucoma is longitudinal data. And by that, I mean lots of different time points where we've seen you over a while to work out how fast things are changing, and what you what you look like today, as well as what you looked like 10 years ago. So it's really helpful. So it's quite hard if you perhaps go and seek a private opinion or without your historical data. And so I'd really encourage you, if you do feel that you're in that position that you do need to ask for a second opinion, that it's important that that historical data goes with you to help the person who's trying to give an objective opinion. So again, that just speaks into although people hate doing visual field tests, for us, there's a lot of noise, and what we're looking for trends in the data, not just individual time points. So we try not to just react to one thing, one of those measurements, but to look over the board to see whether all our parameters are changing, and it's not just a bad day. But yeah, so if you I think chat to people, get lots of information, ask lots of questions, and just go through the other options. But just remember that not having surgery can also be a risk in itself.
Thank you. That's a really, really, really good advice. So thank you very much for that. So we've got one on Reclanda. So is Reclanda, so and again we don't know what what other treatment they're getting. So
So you broke up just a little bit, Conchita. Maybe just repeat the question just so I'm really clear on what that is.
I apologise. Is once a day application adequate for Reclanda?
Yes, so Reclanda is a sort of new drug. It is it's been approved by NICE and guidance, and I have to confess that I haven't got too many patients on it at the moment. So I haven't got, if your follow-up question is what do you think of it? I'm still sort of saving my judgment and seeing how effective it is in the patients I've got in it. But yes, it's meant to be an equivalent to having latanoprost and timolol. So it's not a first line one that we're using at the moment. It's an alternative for people who perhaps we would be recommending having two agents, a prostaglandin like latanoprost, and then a beta blocker like timolol. But for whatever reason, beta blocker for them is contraindicated. So Reclanda comes in as another alternative in that point. And it is a combination drop with a once a day dose. So yes, that's where it falls in terms of our treatment options. How people are getting on with it. It's as I say, I've not got too many patients on it to give you too much feedback on that.
Thank you. So someone has been diagnosed with primary angle closure but no glaucoma, and they've had a laser iridotomy and SLT, but the pressure is not being adequately controlled by the medication. At what point would surgery be considered?
Yeah, so this person has had
a laser iridotomy and SLT, but the pressure is still not being adequately controlled by the medication. So what point would surgery, so I suppose the next step beyond that, the laser treatment, be considered? So they have primary angle closure, but no glaucoma.
Yeah, so this is a tricky group because what you're doing is preventative treatment. And for me, I often just talk to patients and figure out what sort of personality they are. So in terms of people, there are people who like belt and braces and to be absolutely sure that absolutely everything has been done to prevent something happened. And there are other people who say, well, if it's not broken, don't fix it. So This is where sort of your discussions with your team, with your clinicians, is really helpful to work out. So not everyone who has high pressure forever necessarily develops glaucoma, but it is the one of the biggest risk factors we have, and something we can control. In the situation, so primary angle closure means that the drainage is the access to the drainage is limited or closed, and therefore it's hard for the fluid in the eye to get out of the eye. It sounds as if so it's a kind of unusual combination to have had the laser iridotomies. It obviously opened up, but sometimes it might have opened up, but that meshwork still doesn't function so well. So the pressures still remain high. And for some people, it's a case that the production of fluid is more than the outflow facility. Those, and again, it really very much depends on how high those pressures are. So generally anything over 40 is heading for needing some intervention. But actually there is scope for saying, well, if there's no evidence of damage, we could monitor, observe. So it can range from somebody needing to get to theatre as an emergency versus sit on it and watch. I suppose we have got some evidence that comes from the Eagle trial, which suggested that people who were over 50 and had pressures over 30 and had angle closure might be better getting having their lens removed. So in other people, that is thought of as a cataract operation. The procedure is the same, but in cases where we're doing it in angle closure, we're often doing it not because there is a cataract, the lens is still clear, but because it's taking up too much space in the eye. And that was found to be an effective treatment, but in that particular group of patients. So would be tricky if you were less than 50 or if your pressures were less than 30. It would be hard to recommend that as the first line for various reasons. So again, another slightly tricky one without knowing all the details, but there is some evidence that actually people who did have the lens removed, not as a cataract, but in angle closure management, then needed less treatment in terms of drops later on. They lost less vision and they were less likely to go on to need a trabeculectomy.
So you're doing well with all these things that we're throwing at you, I must admit. So, should someone with high iris insertion in both eyes avoid SLT as a treatment?
Yeah, so generally when we're thinking about SLT, although you might come under the diagnosis of open angles, so SLT laser works in open angles. There are some people for whom the configuration of the iris insertion and of how that angle actually looks were all made differently, which is amazing. May just be that there's not enough space to put that laser in. So it's not a sort of definite no-go, but it suggests that it may be tricky to be able to get in and over the hill to be able to apply the laser treatment. But again, sometimes we put the drops in beforehand, and that can change that configuration to create enough space. In other people's, it may not be possible.
Thank you. So we talked about trabeculectomy. It's a one. It's at what stage of glaucoma is a trab advised? When would you advise to have a trab?
Yeah, again, so in my personal practice, and again, this varies between different people, but once you're on 2 medications, if we're heading towards medication number 3, if we can see that there's visual field changes, and for me, I have a cutoff of around about -6. So -6 represents that you are 6 decibels, and I know that sounds funny, but it's how the light in the visual field is measured. If you've got enough of a deviation from normal, that you are in that way, and you've got signs of change. So it might be that if you came to our clinic and that's how you started, but you weren't on treatment, and now we put you on treatment and now that hasn't changed, then that's not an indication for surgery. But it's people who are progressively getting worse. They meet that sort of threshold on the visual field. They're on 2 medications. That's the sort of time when I start having a conversation about surgery. But sort of referring back to the comment earlier about, when surgery right, and what if I don't feel it's the right time, I say I start having the conversations, and gauging with that person what else is going on in their life, how are they managing, all the other factors. So it's a conversation that we start at that point. It doesn't necessarily mean you have to have surgery at that point, but because getting your head around surgery is quite a big deal, it is quite helpful to perhaps have had the seed sown almost a year or 2 years before you need it, that when you get to the point where you need it, you've done enough homework, you've asked all your questions, and we're ready to go, rather than sort of seeing you in clinic going, you need to have surgery tomorrow. That's always a bit of a shock. And I always say to patients as well, when I operate, there's a commitment from me to do the operation for you, but there's a huge commitment from you to be coming back to see me every week in clinic for at least the 4 weeks, if not 8 weeks, which means, not going away, not traveling, just in case we need to sort things out to make the operation successful. So, there are some people for whom they are self-employed. So you want to have those conversations in advance to say, well, when is a time when you can be off work for a significant amount of time, at least a month. Particularly if you're sort of in a manual type of job, that won't, have a huge impact on your income and your life and those sort of things. So yeah, having those conversations is quite helpful, and it's not to scare people, but it's also just to help find, make sure that Conchita, are you still okay?
Sorry, we seem to have lost Conchita. It's probably her internet.
Okay.
So
We've got a few other questions, haven't we, Helen?
yeah, yeah. So UK, so I can, oh, she's back there. She's back. Let's see.
I am so sorry.
No, you're back. Don't panic.
Yeah, my internet threw me out, and I don't know whether it's thrown everybody out. So I apologise. It's given my colleagues time to have a bit of a breather, a bit of a drink. So hopefully, um, everybody's still with us. So I apologise. The gremlins are definitely in there. So thank you very much. So did I'll have to rely on. I don't know how much you answered that, Karinya. Did you manage to answer the question before I threw everybody out?
Oh, I think we all stayed. It was just the recording that went off when you
It was
disappeared.
just me in the recording rather than you. You were all fine. It was just kind of me. I left the party, right? So let's have a go at research. We've actually rather while I'm here, we're having a lot of exercise and lifestyle questions, but we have got a specific support webinar next month. So I'm going to hold all those off. So I apologise, but because we're having so many questions here that we thought we'd carry on and see how we're getting on with the other kind of questions. So we've got a couple of research ones here, Karinya. So has there been any research carried out on the effects of lifestyle improvements or adjustments resulting in the arrest or even the reversal of glaucoma symptoms? Do we know if there's any kind of research that is around?
So there's quite a bit of different work that's going on. The difficulty with lifestyle research is that no one has the same lifestyle. So it's always hard to work out which of these factors is mostly at play. I think the things that if people ask me in clinic, what can I personally do to help my glaucoma, apart from taking the drops and sort of following the advice. So and it's not to say that medical advice is better than other holistic advice, but I guess that's how we function as doctors, that we weigh up the evidence, and that when trials are done, particularly on medication and drugs, all the other elements are standardized. Whereas in lifestyle trials, it is really difficult to standardize a lot of different factors. So we certainly see that people who have busy, stressful lifestyles often have difficult glaucoma to control, and that relates to the hormone which is called cortisol. So in a stressful environment, your body releases cortisol. That cortisol is responsible for lots of different things, so including changing how your glucose is stored or processed. It can be pro-inflammatory, but specifically for the eyes, cortisol is a steroid, and that steroid upregulates the drainage, the meshwork. So I mentioned about this meshwork that's a bit like a sieve, and for some people, the cortisol makes that sieve like a boggy sponge. Therefore, the fluid can't sort of pass through it. Imagine sieving your pasta and all the gooey pasta staying in there. Might work for some people, might not. But just so cortisol and steroids, we know, definitely upregulates and affects the trabecular meshwork. Not in all people, but in quite a few people. Now, when I tell that to people and sort of say, well, you need to get rid of stress, none of us can get rid of stress. Stress is part of life, and some stress is good. But if you are in that situation where actually you're just spinning too many plates, you might need to think about, is there something I could do differently? Are there choices that I could make differently to reduce my stress levels? And that's not always an easy one. You can't always give up work financially or whatever things, but are there ways that you can manage that stress differently? So that then leads on to other aspects, and again, difficult to isolate from stress and cortisol levels, but some evidence that people who practice mindfulness, do deep breathing or rebreathing, can actually help to reduce their cortisol levels. So I guess the advice is generally that anything that is good advice from your general health, so lowering your blood pressure, lowering your, eating well, sleeping well, managing stress, are all helpful things for your glaucoma as well. Obviously, the one that people think about quite a bit is yoga. And there are some really positive benefits of yoga, but there are some cautions with yoga, and that's because when you do a handstand, I'm not sure how many people are listening who are regular handstanders, but you probably remember your face feeling quite flushed and a sort of fullness as the blood rushes to your head. So that creates a bit of congestion and again can put the pressure up. So people who are very regular yoga advocates are just encouraged to be mindful about positions where they are in a prolonged head down position for a long time. So when they did the studies, these are sort of talking about yogi masters who would spend quite happily an hour on their heads a day. So I feel like the advice is, it's not that yoga is a really bad thing. There's a whole lot of good stuff in terms of the breathing, in terms of the mindfulness about it, but it's just being mindful about positions where you are head down for a long time. But there's lots of other positions in yoga that are probably brilliant. So I suppose that's what I say to patients. It is hard to say there's definitely one, there's nothing that gets, cures glaucoma as far as I'm aware. But the general advice to have a healthy lifestyle, to be active, to eat well, to lose weight, to control blood pressure, all the things that we know makes glaucoma worse. So so all the risk factors make glaucoma worse. So doing the right things to avoid the risk factors is preventative.
Thank you. So this is one more. Are there any interesting research outcomes, recent, that you think's quite, even if they're not ready yet, something that you think, oh, that's really exciting?
Yeah, so I suppose the one that I'm kind of waiting for the full papers coming out is around vitamin B3. There is a really great international collaboration going on about trialing additional supplements of vitamin B3 in order to help neuroprotect with glaucoma, and the preliminary results from that have been quite exciting. My feeling is that it's a good thing, but what we don't know yet is exactly what the right dosage is, because the amount that you need to have is quite a lot more than we would have in our natural diet or even in a multivitamin supplement. But vitamin B3 is the one we're sort of or holding out for, if that's helpful, and hoping that it gets over the finish line with a dose that is a good dose that helps the eye but doesn't have any other negative side effects.
Thank you. So we've got one on a general glaucoma question, actually. They have glaucoma in both eyes, had a deep sclerotomy and cataract removal. Um, but sometimes they get unpleasant insect bites, as we all do if we're being outside, and find that Piriton is a great help. But is it safe for them to take Piriton? So obviously they want to take it for the release of that insect bite, but is it safe?
Yeah, so antihistamines do have a little line on them which says don't use if you've got glaucoma. Typically it's the angle closure type of glaucoma. And so typically if you've had your cataract removed, there's usually more space, and I would be fairly optimistic that your angles are open. The deep sclerectomy, so if you had a trabeculectomy, I'd be sort of wholeheartedly, well, actually the eye's got a whole different mechanism for getting fluid out of the eye, and therefore taking antihistamine shouldn't really have any effect or any problem at all. The deep sclerectomy works slightly differently, but again, I think the combination of the cataract and deep sclerectomy is likely that antihistamines shouldn't be a problem for you, but without knowing, without seeing your eye and knowing the status of the angle, again, a good question perhaps to ask your own doctor.
Thank you. For someone with acute normal tension glaucoma, what pressure would be considered too low?
Oh, a really good question, which is often debated amongst doctors, is how low is too low? And the answer is every eye is different. So people with normal tension glaucoma have the changes that we see at the optic nerve and the visual field defects, but they've never had particularly high pressure. Having said that, there is good evidence that if we lower the pressure, things slow down. Trying to slow down the changes from glaucoma. In my thinking, normal tension glaucoma is often related to not just the pressure, but to the blood supply to the eye. And I always encourage patients with that to make sure the blood pressure's been done, the cholesterol's been done, that they're not low on B12 or folate, they're not anemic, there's nothing else that means that the blood flow, the heart's pumping okay and is as well optimized as it can be. Even with people who have pressures of 10, we often still do a trabeculectomy, but it's interesting because of the different way that the physiological resistance at different levels, it's quite hard without surgery to get the pressure lower than 9. So we do often resort to surgery as a way to do that. I have got patients who have pressures of 1 or 2, but the eye is formed and shaped and seeing well. And then I've got people who have got a pressure of 7 or 8, and for them, and even 10, that for them at that pressure the eye sort of seems to collapse a bit like a flat tire, and they can't tolerate that low pressure. So we aim to try and lower the pressure, but it is a real fine line, and there are, as I say, some eyes that can tolerate a very low pressure and other eyes that can't even tolerate, something that we wouldn't say is particularly low if it was a 9 or 10. But with that, they still have problems that the eye aches, that it has these folds in it and that they can't see very well with it. So yes, there are two definitions. One is a numerical hypotony, so that's when the pressure is less than 5, and a clinical hypotony, which is basically the eye telling us that it's not happy with that low pressure and the signs that we would see with that.
Okay. So this person is on, is it sulfagan, lumigan, and pilocarpine? Are any of these unsuitable for pregnancy and conception?
Possibly. So with all the pregnancy is tricky because no one wants to do any trials to see if there are undesirable effects. So there are theoretical changes, and therefore that's the sort of thing I probably would say have a chat with your team about what is the least, what's the safest, and a lot of these things we don't have good evidence for, but again you've got to balance the risk of sight loss from glaucoma versus obviously the risk of problems due to the medication. Again, I just encourage that doing that's quite helpful, but certainly if we often, mostly our patients are in an older population, are usually beyond the childbearing sort of age, so it's an unusual situation to be in, but very much worthwhile having that conversation, particularly around the contraception. So knowing what you would do if you got pregnant, straight away, and how you would get back into the service to say, well, we need to stop this. And again, around the contraception question in terms of planning, so a really good question to ask in advance rather than find out later, or have to navigate that perhaps when you're pregnant. And particularly the first trimester is often the time that people are most at risk for various reasons. So, and often you don't even know, you may not know when you're pregnant. So again, anticipating that and asking that great question with your team would be really helpful.
Thank you. I think we've probably just got one more. Does medication for severe depression affect the eye drop effectiveness?
So there are some medications that are can affect the pressures. They are particularly in angle closure types of glaucoma. So it doesn't affect how well the medication is working, but it might, if it's an angle closure situation, it may be best to consider how that's managed. I'm not explaining that very well, but I suppose what happens is if we have people who are at risk of angle closure and they're on a medication, one of the antidepressants, not all of them, that makes angle closure more likely, we would probably be more inclined to put in some preventative treatment so that they can carry on with their antidepressant medication. I think if you're on it and you've got open angle, then your monitoring systems should just kick in. But again, sometimes being depressed is pretty stressful. So there's other things going on in life, which means that the glaucoma may be struggling. So that we talked about that cortisol. So whether that cortisol is constantly raised, and that can be the case with depression as well. So yes, so I don't think it makes the drops work more effectively. It's slightly the other way around. It may just make your glaucoma a different version or harder to treat.
Thank you. Well, I think we've kind of reached the end of this, so I'm going to have the slide for the next support group, and it is on lifestyle. So sorry that we haven't answered all those questions. They've been coming fast and furiously. So I'm just going to launch the poll again and thank Karinya for her really, really valuable advice. And Also, just to say that if you're making any and thinking of making any changes, please do, as you said, make sure that you consult your team, because obviously it's about them knowing what your personal glaucoma treatment is, and you're not Karinya's patient, so you need to make sure you consult your own consultants. Right. Oh, I think I've actually launched the wrong poll. Let's have a look and see that one. Let's do that one. Try again. Actually, you know what? I think I launched the wrong poll at the beginning, so I very apologise. So I'm going to leave the polls here, and I'm going to end the webinar and thank Karinya for all your help. And sorry about the gremlins, my end, and I look forward to seeing you all at the next webinar. So thank you very much.
Yeah, thank you, Conchita. It's been really great and some fantastic questions. There's no such thing as a stupid question. And the best thing is just keep asking and keep learning. And that really helps you to get on top of your glaucoma. Thanks very much. It's been a lovely evening.
Thank you. Bye-bye.